more sedentary lifestyle compared to areas where they tend to be more active, work to farm, active at their farm, thereby reducing the incidence of getting hypertension. And it's also important for us to know that hypertension is the main driving factor for strokes in Ghana. A study done by Safo et al. Showed that hypertension is the main risk factor for stroke in patients in Ghana. Then also, if you look at causes of heart failure in Ghana, hypertension is so the leading cause. And also in renal failure, hypertension is so the leading cause of renal failure in Ghana. Then there was a study that was done in Ghana that showed that was in 2017, about 15.3% of the total death in Ghana was attributed to hypertension, and that really makes it so serious even in Ghana. Now let's talk about hypertension-mediated organ damage. It can be defined as when you have a significant damage to various organs in the body, or it can also be defined as a phenomenon, a condition where you have significant damage to the organs in the body. In terms of severity of hypertension-mediated organ damage, it ranges from mild to severe, potentially leading to conditions like hypertensive emergencies. And HMOD is common in severe hypertensive patients or long-standing hypertension. But you have to also know that occasionally it's seen patients with asymptomatic, patients who are symptomatic, high elevated pressure. So hypertension-mediated organ damage can still be referred as a structural or functional changes in key organs due to chronic high pressure. And it's important for us to know that it's a major predictor of cardiovascular events and then poor prognosis. In other words, the presence of HMOD confer incremental prognostic information risk at every HMOD, and then it's more so when the damage affects multiple organs. So once you are having multiple organ damage, then the CVD risk increases markedly. Now let's look at the evolving hypertension-mediated organ damage. Initially, it was called end organ damage, and later was also called target organ damage. But now the preferred term is hypertension-mediated organ damage. But let me also say in passing that some of the tests also use hypertension-related organ damage or hypertension-induced organ damage. So we have to note this. But then now the preferred term is hypertension-mediated organ damage. In terms of pathophysiology, I must say that hypertension-mediated organ damage arises from a complex interplay of hemodynamics, stress, neurohormonal dysregulation, oxidative stress, immune activation, and the fibrotic remodeling. And this complex multifactorial pathophysiology form part of a complex cardiovascular concept termed as cardiovascular continuum, where in this concept of cardiovascular continuum, you have the risk factor, for instance, hypertension, that causes, when it's uncontrolled, causes left ventricular hypertrophy, and left ventricular hypertrophy through arterial dysfunction results in arteriosclerosis. Arteriosclerosis also then lead to coronary artery disease. And when there's any rupture of the vessel, it can then lead to myocardial infarction. This myocardial infarction will then continue and then predispose the patient to get some fatal arrhythmias such as ventricular tachycardia. That can even lead to sudden cardiac death. And if the patient survives this insult, it can lead to pathological remodeling. And then the patient developing left ventricular hypertrophy. Then congestive heart failure may ensue. And eventually the patient may end in end-stage heart disease. So this slide is so showing or trying to give a detailed pathological explanation of the cardiovascular continuum, where you have the risk factor hypertension in this particular instance, causing mechanical stress or oxidative stress, and that will result in inflammation. Inflammation will cause early tissue damage from endothelial dysfunction, and that will predispose the patient to get arterial thrombosis and then progressive cardiovascular disease. And then that may result in tissue injury. A tissue injury here, you are talking about myocardial infarction, you are talking about stroke, you are talking about renal insufficiency, you are talking about peripheral arterial disease. So when all this happens, then if the patient survives, then the patient develops the pathological remodeling, and that results in the various or multiple target organ damage, which later will result in end organ failure, like congestive heart failure or end stage failure. Eventually, the patient may die from this insult. Now let's try to look at some of the forms or types of neurologic, types of forms of hypertension-mediated organ damage. The first one that we want to look at is the neurologic complications. And you can have some severe form of neurological complications such as hemorrhagic stroke, ischemic stroke, when this patient may present with dense hemiparesis, or some of these patients may present with confusion. That's when they are having hypertensive encephalopathy. Or this patient may present with severe headache, where sometimes they will say that this is the severest headache they have ever had, meaning that they are talking about subarachnoid hemorrhage. Of course, other subtle changes may occur in the brain, which may include TIA, small vessel disease, vascular dementia, and then what have you. So these are those complications that can occur when this hypertension-mediated organ damage is involving the neurological system. Then also it can affect the eyes, where the patient may have hypertensive retinopathy. Patient may have retinopathy. That will occur due to destruction of the microcirculation of the eye. And the changes that occur are have stage 1, which is sometimes described as copper wiring or silver wiring. And then we have stage 2, that's why AV nipping. And the stage 3, they have various hemorrhages. And the last but not the least, the last stage, which the severe form, is where they have what we call papilloedema. So these are the stages that occur in the eyes when hypertension affects the organ to the term hypertension-mediated organ damage. Now the heart, which is also important, where hypertension tends to affect the heart in several ways and several mechanisms. And the pathological effect that occur with the heart in the form of hypertension-mediated organ damage are left ventricular hypertrophy. The first one, left ventricular hypertrophy. Of course, when uncontrolled hypertension consistently affect the heart muscle, that results in hypertrophy. And that may also lead to left ventricular dysfunction. Other more severe cardiovascular disease that can occur when this affect the heart include coronary artery disease, of course, myocardial infarction, and soon after that, then may also present with angina pectoris, and then heart failure may also occur in that process. Now hypertension-mediated organ damage can also affect the kidney, where it may present with chronic kidney disease, or may present with just hypertension nephropathy, or sometimes just presence of albumin in the urine, otherwise known as albuminuria. So these are some of the also changes when hypertension affects the kidneys. So the types or forms of the hypertension-mediated organ damage involving the arteries, where we may have peripheral arterial disease. The patient may sometimes present with intermittent claudication. And then when you check for ankle brachial index, some of these patients may have a figure of less than 0.9. And that shows that there's a problem with the arterial system. Now, this slide is showing a spectrum of hypertension-mediated organ damage. So you have the eye involvement, you have the heart with all the various pathology involving the heart, and then you have the kidneys also with various pathologies, and then the brain, of course, very important, where you have all the strokes, hemorrhagic or ischemia, you have hypertensive encephalopathy, you have cognitive impairment, vascular dementia, and what have you. The question then is, why this presentation? Why are you having this presentation? The reason being that there's rising burden of non-communicable diseases. And most of these non-communicable diseases, the primary factor behind it, or the primary force causing is hypertension, through this hypertension-mediated organ damage. So it's important that we have this type of presentation to create awareness so that we can get understanding and knowledge to be able to manage hypertension and manage it very well. So why this presentation? This presentation is so because in 2016, where they looked at the top 10 global causes of death, the first one was ischemic heart disease, second one stroke, and these are all forms of cardiovascular disease, of which the main cause of this hypertension. So that if you are talking about top 10 cause of death in the whole world, and you are mentioning ischemic heart disease, stroke, and hypertension behind that, then it's very important that you have a presentation like this to be able to know how you can have the update about management of hypertension to prevent all these complications. So why this discussion, why this presentation this afternoon? We are saying that when hypertension-mediated organ damage is present, it upgrades an individual's cardiovascular risk, where, for example, a patient with low risk will then be upgraded to moderate risk, which may indicate initiation of treatment for that patient. It's also important for this discussion is also important because when there's presence of hypertension-mediated organ damage, it guides the patient in terms of when to start medication for the patient to prevent complications happening to the patient. It's so important for us to know that when there's presence of multiple hypertension organ damage in the same person with suspicion of secondary cause, then so when there's presence of multiple hypertension-mediated organ in the same person, can raise a suspicion of a secondary cause for hypertension and further escalate the cardiovascular risk in that patient. Now, let's look at this slide showing evidence of left ventricular hypertrophy, both on ECG and the echo. We are saying that any patient with hypertension having left ventricular hypertrophy increases the risk of the patient, the cardiovascular risk of the patient. So it's important that routinely we do ECG to be able to pick up or detect the left ventricular hypertrophy. Or more importantly, you can also do echo, where you can see the left ventricular hypertrophy, left ventricular mass, can even detect the left ventricular diastolic dysfunction in this patient to be able to help manage the patient well. So this slide is also showing evidence of left ventricular hypertrophy. And this was a study that was done. And the study showed that the presence of marked left ventricular hypertrophy increases more of the negative effects of this hypertension-mediated organ in the presence of hypertension. So when the patient is having marked left ventricular hypertrophy, it increases the risk more. Earlier, we said that when the hypertension affects the kidney, the patient may present with albuminuria. And that one shows that, and it's been documented that albuminuria albuminuria is a marker of kidney damage, which increases the risk of cardiovascular hypertension. Would increase in the urea albumin catching ratio and the all-cause mortality by about 75%, 75.2%, and then stroke by 51%, and then also myocardial infarction by 45%. That shows that albuminuria is a major important cardiovascular risk factor that if you see any patient with hypertension presenting with that, you need to find out and manage as such. Now, this was a study that was published in the Journal of Hypertension. It was a study that was done in Africa, where it was really a meta-analysis that looked at low awareness, target organ damage, and the cardiovascular complications of hypertension in low resource setting. And the study shows that low awareness, target organ damage, and cardiovascular complications tend to occur in patients with Africa-centric compared to the developed countries. And the reason that were attributed were the fact that these patients tend to get to the hospital late, and also how to do with the fact that sometimes these patients don't have even money to go to hospital. So hence they have all these complications from the hypertension. So this also a very important study that was done in China. So it's a Chinese study where this study look at the different grades or stages of hypertension. And the study showed that the severe hypertension tend to cause more hypertension-mediated organ damage than patients with low or moderate hypertension. So it means that it's very important that we manage our patients and manage them well so that they don't develop severe hypertension to have all these complications. In the same study, yes.
Have about 10 minutes to round out, please. Thank you.
Okay, thank you. In the same study also showed that a patient with controlled hypertension tend to have less hypertension-mediated organ damage compared to uncontrolled hypertension. So also it's very important that we have to manage our patient well to prevent all these complications that occur with hypertension. How can we diagnose hypertension-mediated organ damage? And it's important for us to know that early identification of hypertension-mediated organ damage is crucial for risk stratification and therapeutic decision-making. In trying to diagnose, you need to go through process of hypertension. You need to go through the history of hypertension, and then also want to examine the patient and then do relevant diagnostic testing. Of course, it's important to know that this hypertension-mediated organ damage tend to occur in patients with severe hypertension, patients with poorly treated hypertension, patients with long-standing hypertension. So we need to know that. In the testing, there are a number of investigations that can be done. The key investigations that we routinely do include renal function. So renal function, where you can assess the creatinine level, can assess the urea level, you can estimate the eGFR, and also very important, the urea albumin to creatinine ratio to detect nephropathy, which we said earlier that it's a negative factor when you are dealing with hypertension-mediated organ damage. Of course, we also want to do cardiac assessment, where we want to do 12-lead ECG, where we can pick left ventricular hypertrophy. We can also do echo, where we can assess the structure and the function of the heart. So you can detect left ventricular hypertrophy, left ventricular hypertrophy mass, and then left ventricular diastolic dysfunction. You can even assess the ejection fraction of the patient with the echo. So with the evaluation, you can do vascular evaluation, where you can do carotid femoral vein pulse velocity to assess the arterial stiffness and the ankle-brachial index for peripheral artery disease. Then also very important to do ophthalmologic examination, where you do fundoscopy to assess or detect hypertensive retinopathy. of course, more importantly, you want to do neurological imaging. Here, MRI is very important. Of course, you can also do CT scan, where you can pick some of this hypertensive-mediated organ damage. Now, how can we prevent hypertension-mediated organ damage, which we are saying that is a major cardiovascular risk factor when in the presence of hypertension? Some of the ways that we can do to prevent or reduce to do early diagnosis of hypertension. So once you diagnose early, then you can manage aside to prevent hypertension. That's why it's important that we increase awareness of hypertension, and of that also encourage screening of hypertension. So the point here is that early detection and treatment of hypertension are crucial to prevent or minimize or delay the onset of hypertension-mediated organ damage. Why early detection of hypertension-mediated organ damage is important? One, because it provides therapeutic guidance for management of patients with hypertension. And also, it's also involving preferential selection of drug treatment based on specific impact of the hypertension-mediated organ damage. So the essence of diagnosing this, how we can prevent. Optimal management is one of the ways that we can employ to prevent this hypertension-mediated organ damage. And it's important to say that medications are necessary to control pressure and then prevent organ damage. The management of hypertension-mediated organ damage has evolved significantly, integrating early detection, aggressive blood pressure control, and then organ-specific protective strategies. With that, it's important to say that for effective management of hypertension, involve both lifestyle changes and then medications. While with treatment, the goal is that you need to achieve adequate control of BP and maintain it at a target level, control of the risk factors, and promote healthy lifestyle to reduce morbidity and then mortality. So these are some of the benefits of treating hypertension, where in this study said that a 10 milligram reduction of systolic blood pressure or 5 milligram reduction in diastolic blood pressure is associated with significant reduction in all major cardiovascular events by about 20% and all-cause mortality by about 10 to 15%, and the stroke by about 35%, and the coronary event by 20%. Also importantly, heart failure as high as 40%. So that reducing pressure is very, very important in hypertension management and its complications. So this is the slide showing how lifestyle modification can be employed. Where we need to reduce weight, we need to employ diet. We need to encourage the patient to reduce sodium intake, encourage physical activity. And of course, you want to stop alcohol or moderate alcohol use. Also important that patient that take elderly patient that takes particular sugar sweetened beverages have to stop to prevent this complication that occur with hypertension. With the medication, starting medication depends on one, the level of pressure elevation, and the two, the patient overall cardiovascular risk. And then with that, we are saying that hypertension management should be individualized according to characteristics of each patient. So it is difficult to generalize. You can't use just one approach to manage your patient, because patient generally differs in terms of characteristics. So this one is very, very important. So these are some of the drugs that can be considered in trying to manage patients with hypertension-mediated organ damage. We have calcium channel blockers, ARBs, ACE inhibitors, and the thiazides can be used. Of course, you need to consider compelling indication when you are managing this patient. Now, all the guidelines, the major guidelines support that you should use combination therapy. So combination therapy is now the preferred choice for managing hypertensive patients. the essence of combination therapy has to do with the fact that there's increased antihypertensive efficiency. It also reduces adverse effects. It also enhances convenience and the compliance. And last but not the least, potentiate for additive target organ protection. This was the study that looks at how multiple drugs can be used to achieve BP control. So there are quite a number of studies that can be done that confirm or support the fact that the way to go in controlling patient BP is to use combination therapy. This also, the value trial and the accomplished trial, more two recent studies that was done to support the fact that combination therapy is the way to go if you want to control patient with hypertension. And the slide is showing some of the drugs and their combination, where, for example, if you want to use a combination therapy, you want to use either AC inhibition or ARB, plus calcium channel blocker or diuretics. It's very important to know that you don't combine AC inhibitor and ARB. So it's either ARB or AC inhibitor plus calcium channel blocker or diuretic. So these are some of the combinations that can be used in treating patients with hypertension. Now with monitoring, it's very important or essential that patient with hypertension-mediated organ damage, you need to monitor this patient. So you have to be checking the patient BP regularly as much as possible. And then occasionally want to do some investigation to check any organ damage in that context. Now they are talking about hypertension-mediated organ damage, and that's where research is being done to able to confirm its usefulness in diagnosing hypertension-mediated organ damage. So in conclusion, I'm saying that hypertension-mediated organ damage is a serious consequence of hypertension that can affect multiple organs and increase the risk of cardiovascular disease. And that hypertension-mediated organ is a critical aspect of hypertension management, so that early detection and blood pressure control can either prevent or reduce or delay or even reverse the hypertension-mediated organ damage. And so we are saying that we are now focusing on these plasma biomarkers in trying to diagnose hypertension-mediated organ as early as possible. And the take-home message for this one is that hypertension-mediated organ damage is a critical marker in hypertension. As such, we need to manage hypertension, well to prevent this hypertension-mediated organ damage ensuing. So thank you for this opportunity. But let me say that yesterday was the World Hypertension Day, and Kumasi Zone, we had a powerful float and then screening where a number of people attended. There was a massive turn-up, and I want to take this opportunity to thank all the organizers of Kumasi Zone health work and then free health screening that was done in Kumasi, Dubai. It was this recently that I got to know that there's also Dubai in Ghana. I thought Dubai was somewhere, but then here in Ghana, Kumasi have Dubai, and that's where we had this powerful free medical screening as part of Ghanaian Society of Cardiology, championing hypertension awareness and screening in Ghana. So this slide showing the turn-up that was so massive, was really massive. Thank you very much for the opportunity. Thank you for your attention.
Thank you very much, Dr. Emmanuel Achemfo-Akowa. Our speaker is a cardiologist in Kumasi. We are very grateful for this exceptional presentation on hypertensive-mediated organ damage, and we have really learned a lot this afternoon. We will take the next two presentations before opening the floor for questions and contributions after all the three. At this point, I'd like to remind our attendees to put any questions or contributions that they have in the Q&A box. And then I'm going to introduce, he has already been introduced, but I'll introduce him briefly. Our next speaker, who is in the person of Dr. George Pepra, is the only cardiologist serving the Western zone of our country. And he also doubles as the medical superintendent of Takoradi Government Hospital. He is going to give us a presentation on hypertensive emergencies in adults. He has started sharing his screen already, which means he's very ready. Dr. Pepra, please, your audience. Thank you.
Thank you, Na, and thank you, Chairman Dr. Ajekun, for this privilege. So I'll be looking at hypertensive crisis in adults. And to begin my presentation, like to take our mind on this, that Ghana and hypertension is no news that hypertension is the leading killer of the adult population in Ghana. It's the leader cause of serious complications, which I'll be looking at, including stroke, heart failure, kidney failure. And I believe hypertension should have a controlled program, i.e. hypertension control program, just like malaria control program, national tuberculosis control program. Because as a nation, the communicable diseases, we've done well with them, but now the NCDs are what is killing us, and there should be proper effort to try to control this cancer that is killing the adult population. The elephant in the room now is hypertension. I mean, there is no condition in the country now that can be compared to hypertension. So definitely hypertension should receive major concern. And then hypertension should be a disease of public health concern. And this one, my regional director told me yesterday that it is already under public health. And I think that's a good way to go, because we should look at primary efforts to control hypertension. And then the focus should be on hypertension prevention, which is primordial, primary and secondary, and then tertiary. I mean, we should focus more with the primary prevention, and when complications comes, the secondary preventions too, we looked at it. And there should be a national policy formulated to control the menace of hypertension. Children have their weighing book, pregnant women have their red book. Every Ghanaian should also have some health book. So what about having an adult weighing book, which have record of your BP, your weight, your height, your cholesterol level, all these things, and having a policy that make it a requirement that each and every one of us have such health record. Possibly if you are going to look for employment, you should carry your adult weighing book along. Or if you are going for driving license, you should carry this along. All that I'm saying is that the country should make an effort to control hypertension, because that is what is killing us. So we've looked at the definition of hypertension already. My senior boss has done justice to that. And there is importance in recognizing the hypertensive crisis, which I will be talking about. And we say hypertensive crisis when the blood pressure hits 180 over 120 millimeters of mercury or more. And it is important that we differentiate between urgency and emergency. Hypertensive urgency and hypertensive emergency come under hypertensive crisis. And in both situations, you have the blood pressure 180 over 120 or more. But in hypertensive urgency, there is no acute organ damage. Whilst in the emergency, there is an acute organ damage, and that defines their treatment goals. Chronic hypertension has been presented already leads to hypertensive mediated end organ damage. The heart may suffer hypertrophy, the kidneys may suffer chronic kidney disease, the eye may undergo retinopathy, various grades of them. In fact, blood goes to every part in the body. So when the pressure that is carrying the blood to that organ is excessive, it damages the organ. So since blood moves to every part in the body, definitely every part of the body can be damaged by hypertension, and so it does. Acute hypertension can lead to acute organ damage. So the hypertensive mediated damage that we've looked at, there are some that happens as a result of long-term high blood pressure, like left ventricular hypertrophy. The left ventricle, if it's under pushing against high pressure, it takes time to build muscle. But when the pressure goes up acutely, that left ventricle may fail, and the patient may have an acute left ventricular failure, and that will come under the acute hypertension, leading to the acute organ damage. And then you have organs that we should be worried about when we have these hypertensive crises. So the organs, starting from the top, the brain, and then the eye. If you come to the chest, the heart, lungs, and then the aorta, the biggest vessel, can be damaged by hypertension. And as you go down, you have the kidney. For women who are pregnant, hypertension can cause havoc. And then sympathetic overactivity can also lead to hypertensive emergencies. And autoregulation is an important concept that we need to understand when it comes to treating hypertensive crisis. So if you look at this diagram, the blood, most blood beds have local autoregulation. That is, they control the amount of blood that flows into them. And using the example of the brain, has an autoregulation where blood pressure from 50 to about 150 have a constant cerebral blood flow of about 50 mils per 100 millimercury per minute. That is, I mean, between 50 to 150, there is a constant flow of about 50 mils of blood into the brain. Now, if it so happens that the blood pressure, which is the systemic blood pressure, drops below 50, what happens is that the cerebral vessels will try to dilate in order to have more blood flowing. But unfortunately, below 50 is difficult to keep dilating, and it actually goes the opposite way and may become constricted, and that brain may suffer ischemia. This concept becomes very important when we are looking at ischemic stroke, where when there is narrowing, when there is blockage, whereby blood flow to the brain is reduced. If we reduce this blood pressure further, it's going to result in almost no flow into the brain at all. On the other side too, when the blood pressure is excessive, I mean, it goes beyond the 150, it may so happen that, I mean, what happens in the autoregulation region is that as the blood pressure increases, the cerebral vessels narrow so that a constant amount of blood flows into the brain. But once it reaches the end of its autoregulation at the higher end, it's not able to continue narrowing, and then it may actually go the opposite way, dilate, leading to more blood flow into the brain, leading to edema and then brain damage. And this is the pathophysiology that happens in patients with hypertensive encephalopathy, where extremely high BPs may actually lead to cerebral edema and causing various presentations. So Autoregulation is important, and this autoregulation occurs in almost all vascular beds. And in managing hypertensive crisis, we need to understand this principle well. Patients, the normal autoregulation, as said, is about 50 to 150. Patients with chronic hypertension usually have their autoregulation shifting to the higher end of about 100 to 200. So somebody coming with an ischemic stroke and the blood pressure, the mean arterial pressure is about 150. If you should drop that mean arterial pressure to about 100, which is actually normal for the normotensive, it may be catastrophic for the hypertensive because that patient has his or her autoregulation shifted forward, and reducing that pressure acutely may cause havoc for such a patient. So let's look at the hypertensive urgency. The definition is having severe hypertension, which is 180 over 120 or more. And in this situation, there is no acute organ damage. The organs that we mentioned about, there is no damage to any of them. It's just the blood pressure that has gone up. And in evaluating this patient, you only make a diagnosis of hypertensive urgency after you have ruled out hypertensive emergencies. That is, you need to make sure that the organs that we mentioned, the brain, the eye, the heart, lungs, the kidneys, if there is pregnancy, the preeclampsia and those conditions are not there before you finally say this patient has hypertensive urgency. So that is very important. And then confirm the presence of severe elevated BP through repeated measures using proper techniques. This is also very important. Before you label the patient, make sure the blood pressure has been checked correctly. You need to take a full history, examine the patient very well. Some situations you may need to do certain labs before you allow the patient to go home that, okay, what you have is just hypertensive urgency and not an emergency. They may have mild symptoms like mild headache. I mean, patients come to us with headache all the time. We don't request CT scan for all of them, but there is a type of headache that become that you want to do a CT scan. So hypertensive urgency may come with some mild headache, some dizziness, a slight visual disturbances, which has probably been there for ages, and that may come with urgency. And the management here is to aim for a gradual reduction in blood pressure over 1 to 2 days using oral antihypertensives. So that is urgency. And in most situations, you can treat this patient on OPD basis. But it's a study, the stats registry, that showed that unfortunately, most of these patients are lost to follow up as soon after evaluation, and they return to the emergency department with recurrent uncontrolled hypertension within 3 months. That's quite unfortunate. And in addition, you have to also look at patients at high risk of acute cardiovascular events. So does the patient have hypertension? Does the patient known to have coronary artery disease or has suffered a stroke before? If there are some of these high risk patients coming in with just hypertensive urgency, you may want to admit such a patient and make sure you have slowly controlled their blood pressure before they go home. And then urgency BP 180 over 120. And the blood pressure target in urgency is to aim for gradual reduction over about 2 days. So over 2 days, you want to bring the blood pressure to about less than 160 over 100. And in the long term, usually within 3 months, you want to bring this blood pressure to normal, because bringing it to below 160 over 100 is not enough. You have to see this patient regularly within 3 months to make sure that finally that blood pressure is brought under control. For most patients, you need to aim for below 140 over 90. And for young people and adults who are strong, you may aim for below 130/80. that offers them better risk protection from cardiovascular events. And then in the emergency situation, the targets are different. I brought it early. We'll look at it again. Here, you are aiming for about 10 to 20% drop over the first hour. So if blood pressure is very high, you want to aim for just bringing it just below the definition of severe hypertension. And over the next 23 hours, you want to bring it down further by about 5 to 15%. So if you look at it in the first 24 hours, the overall drop should be within 25, maximum about 30% drop within the first day, which is the first 24 hours. That is your aim. And then over 3 months, you bring them to normal as with the urgency situation. So for the hypertensive urgency, you take about 2 days to bring it down to about below the 160, 100. And for the emergency, you take about a day to do that. The treatment is to resume their antihypertensive therapy. So if the patient was on antihypertensive and they have stopped taking it, in the urgency situation, all that you may do is to restart their antihypertensives, give them shorter reviews, and then you review their drugs until it's controlled. And if the patients are naive, I mean, if never taken an antihypertensive before, you want to initiate them. And in patients who are on treatment, they haven't defaulted, then you may want to add more antihypertensives or increases the dosages of what they are already on to ensure the blood pressure is controlled. And to control their blood pressure, we've already looked at this. We have the ABCDs. In most situations, B, which is a beta blocker, is not first line drug. You only use a beta blocker when it is indicated, like patients coming in with tachycardia, hyperthyroidism, heart failure, acute coronary syndrome. It's those situations that you use a beta blocker. But in just controlling the hypertension, the first line drugs are ACD. So A for ACE or ARB, C for calcium channel blockers, D for diuretics. You may use any of these two. So you may do A plus C, A plus D, or you may do C plus D as first line. You may start with low doses of any of these two combinations. And then second line, if it's not controlled, you may do higher doses. So you may do, say, lisinopril 5, amlodipine 5. It's not controlled over 2 weeks review. You go up to lisinopril 10, amlodipine 10. If it's not controlled in the next review, you may add a diuretic, which is a thiazide-like diuretic, bendro, indapamide, or any thiazide-like diuretic, and that will become the third line. So you do ACD, all three together. And when you are doing all three and still BP is not controlled, the fourth drug to bring on board usually is a spironolactone. And you can also use a Plerenol. And by and large, these 4 drugs will control most BPs. Will control over 90% of the BPs. So using these ACDs will help us control most blood pressures. If the BP remain uncontrolled, then you have to look for either the patient is not taking the medicine or there are secondary causes of the hypertension. You have to evaluate for that. We have to reduce their blood pressure gradually in urgency, but there are these 2 major concerns. The risk of adverse events if lowered too rapidly. So that is what I've been preaching for the past 10 minutes, that we have to do it gradually. But the second problem is there is a potential risk of imminent cardiovascular events that may result from the severe hypertension if the blood pressure is not quickly and sufficiently reduced. So though you aim for gradual reduction, the BP is not, is a silent killer. If it's remaining above 140/90, it's causing damage. It's causing all the complications my senior spoke about earlier. So it is important that you aim to control the BP within 3 months as much as possible. We move to the emergencies. So the emergencies basically is an emergency with end organ damage. So in this situation, there is damage to any of these organs being shown. So starting from the top, we have the brain and the eye. So if a patient comes in with symptoms of neurological symptoms or eye symptoms, you may want to consider an emergency. If it comes with heart symptoms, two main things, either a heart failure syndrome or acute coronary syndrome. If you come with any of these symptoms, maybe an emergency. The patient may present with aortic dissection, and that is an emergency. They come in with dyspnea if they have the heart failure, with fluid in the chest. So they come with dyspnea, pulmonary edema, and then this high BP can damage the kidneys acutely. So a patient may come in with AKI, and in pregnant women, they may present with preeclampsia and eclampsia. And for those who may be taking certain drugs, they may also come in with hyperadrenergic crisis. So the treatment here is immediate BP reduction. And here, we are not going to use oral medicines like the urgency. You are going to use IV antihypertensives as much as is available. So what are the causes? Usually, these patients are on antihypertensive, but they have stopped their medicine. Or the hyperadrenergic ones, they may be taking cocaine, methamphetamine. I don't know what is in red. Maybe may also come in with that. And then kidney, so acute kidney injury in itself can also present with hypertensive urgency in other organs. And then endocrine disorders, these secondary causes of hypertension may also present with emergencies. And the risk factors here are those with chronic hypertension, high salt intake, and then people with stressful and those who are anxious. So diagnostic approach, history, physical examination, and you do laboratory tests depending on which organ you think is damaged. In some of the situation, you may need imaging as well. So for the eye, we're talking of retinopathy, and we are looking at grade 3 or grade 4 retinopathy. So a retinopathy, which is grade 1 or grade 2, that one, the chronic hypertension may present with that. Chronic hypertension may also present with grade 3 or grade 4 retinopathy, but it might have developed over a long time. But if a patient comes with sudden or a very short period of blurred vision or loss of vision, and you looked into the retina and you see hemorrhages in the retina, or you see edema, that would be grade 3. If you see papillary edema or the macule is edematous, then you'll be thinking of grade 4 hypertensive retinopathy, and that patient has hypertensive emergency. So a patient high BP, blurred vision, it could be an emergency. The brain, so they can come in with hypertensive encephalopathy or stroke. It may be an infarctive stroke, hemorrhagic stroke, either intracerebral or subarachnoid hemorrhage. So that's how they will present. For hearts, it may be the aortic dissection, acute left ventricular failure, or MI. And then for the kidney, they may present with acute kidney injury. And then women who are pregnant, preeclampsia or eclampsia. Those will be the hypertensive emergencies we have to look out for. So subarachnoid hemorrhage may come with the worst headache of his or her life. So that's what we'll be looking out for. And encephalopathy will come in with generalized neurological symptoms. So we may have agitation, be delirious, have stupor, seizures, and various generalized presentation. For stroke, whether it's infarctive or hemorrhagic, they may usually come with focal neurological symptoms. So hypertensive encephalopathy usually come with generalized neurological symptoms. Stroke may come with a focal neurological symptoms. And then retinal hemorrhage or edema, they may come with acute visual problems. For the heart, acute chest pain or chest discomfort may be the presentation. Aortic dissection, the classic presentation is severe chest pain that radiates to the back. And for pulmonary edema, you come in with dyspnea, will not be able to lie down. You want to sit at the edge of the bed. Preeclampsia, any pregnant woman with severe hypertension, you should have to look out for preeclampsia and also look for drug use for those who have hyperadrenergic presentation. So what test will you do? The test should be directed by your history and examination. So if you think this patient is having a heart problem, you do your ECG, your chest X-ray, your echo. If you think the aorta is involved, you may want to do a chest X-ray. If you have echo, you do it immediately. For the kidney, your urine analysis, and then your BUE and creatinine will be needed. Pregnancy, if you suspect it, you do your UPT. And then for heart vessels, there is coronary arteries. You may do your cardiac biomarkers if you're thinking of ACS. Brain eye, you may need a CT scan.
Mr. Pepper, sorry for barging in, but we may have to wrap up over the next 5 minutes. So thank you.
Okay, thank you. So the aorta, you may do your CT scan or MRI. So preeclampsia basically is like hypertensive emergency in the pregnant woman. So most of the organs we've spoken about, they may be damaged to these organs. And if you have damage to any of them, then you may make a diagnosis of preeclampsia. And here the BP is 140/90 or more. And then their treatment, generally for all of them, as said earlier, you are aiming for about 25% drop in the first 24 hours. Most of it, you do it in the first hour, but you are going to use IV drugs, preferably in the ICU. And in the long term, you continue with oral medicine after the first 24 hours to control the blood pressure. There are 3 major exceptions to this general rule, and one of them is ischemic stroke. As said earlier, due to the autoregulation problems of the brain, if the blood pressure is below 220/120, you may actually not be in a hurry to start antihypertensive in the first 72 hours. So the ESC guidelines actually advise that below 180/105 for ischemic stroke, don't start antihypertensives. Wait after the first 3 days before you initiate treatment. For those who come in with hemorrhagic stroke, your goal is within 6 hours, bring it down to about below 160. And then those with acute aortic dissection, this is where you drop the blood pressure. In fact, here, the aim is drop the blood pressure. So within 20 minutes, if you made a diagnosis of acute aortic dissection, drop the pressure to as low as 100 or 120 of the systolic. And you're going to use beta blockers for these efforts. Mostly, we have labetalol and hydralazine around. Labetalol is preferred because of the precipitous drop with hydralazine. For cardiac emergencies, it may be acute heart failure, ACS. Yeah, the presentation will tell you which drugs to use in most situations. Aortic dissection, I've spoken about it. The drugs that can be used are there. For kidney emergencies, you have to drop it gradually using the general rule. And for sympathetic overactivity, again, drop it using the general rule. Don't be too aggressive. And then in pregnant women, again, use the general rule. And you may need magnesium sulfate to prevent seizures. So this is a case presentation. somebody 55-year-old male coming with BP 190/120 is high. You only have mild headache. You've gone through the history, nothing else. So that's an urgency. But a similar patient comes, this time chest pain is confused. You may be thinking of emergency. And this here, I saw this patient, in fact, today. He's had hypertension since 2022. His BPs have been very high. His main presentation were just to dizziness. He says it feels like falling when he's walking. He had been on the ACD, but the BP was not controlled. It was changed to S4, which is another ACD, in addition to spironolactone, which is the fourth-line drug, very good. Still, BP was not controlled. And when it came, if you look at the ODQ here, basically what I was doing was looking at the end organ damage. So I was looking for headache, dizziness. He has it, but it wasn't the kind of headache that will make me go and do a CT scan. And he didn't have any weakness to any limbs. So I didn't think he had a stroke. He had no visual problems. He had no chest pain. He had no shortness of breath or difficulty in breathing or orthopnea. There was no abdominal pain, no oliguria or hematuria. So you need to go through this to be sure that you don't have any end organ damage. Past history is only hypertension. He was taking alcohol, he stopped. Systemic inquiry, again, we examined these organs that could be involved in emergencies. I didn't find anything. The ECG, he had a long-term damage to the heart, which is left ventricular hypertrophy. He also had a left axis deviation. Echo, the walls were quite thick. Ejection fraction was okay. So finally, I thought this patient has an urgency. And one of the main presentation was tachycardia. In fact, his heart rate was 124. So I said, continue with your ACDs. And then I added a carvedilol and to see him in 1 week. So prevention and follow-up, the important thing is make sure these patients adhere to their drugs and the lifestyle changes that was spoken about earlier. Regular monitoring, home BP check, routine clinic visits are important to control BP, and we have to individualize their treatment plan in emergency. Early recognition is key in preventing these organs from being damaged, and we need to differentiate urgency from emergency to guide management, and timely intervention prevents complications. Thank you very much.
Thank you very, very much, Dr. Pepra, for such an insightful presentation. It's been quite in-depth, and we are very grateful. Without much waste of time, because we are far behind, we would like to move on to the third presentation to look at our pediatric emergencies. Dr. Christiana, if you're on the call, kindly start sharing your screen. We have some questions, and please, to the participants, keep posting up your questions in the Q&A box. When all the presentations are done, all the presenters will remain on the call to address your concerns. And for those who want to speak in person as well, yes, you will be allowed to speak and ask your questions. Dr. Christiana, please, if you're on the call, can you kindly share your screen?
Hello, Dr. Christiana, can you give us a hi if you can hear us?
Yes, I can hear you. So I'm just sharing my page shortly. Sorry. Just okay. Can you see my page?
Yes, please.
Yes.
Okay. All right. Good evening, everyone, and thanks to GSC for listening to very wonderful presentations that have gone on. I would say that Dr. Pepra and Dr. Akua have made my presentation easier, especially Dr. Pepra, because you hinted on a lot of the things that I'll be talking about. So I'm hoping this will move fast. So we are in a minority, pediatrics, and so anytime we have the opportunity, we try to launch ourselves, let the adults know a bit more about pediatrics. My name is Christiana Edutachi, and thanks to GSC organizers for this opportunity. So my aim in presenting on pediatric hypertensive emergencies is for us to understand when elevated BPs require emergency, urgent, or just the routine care. And I'll issue this disclaimer that contrary to adults, the pediatric hypertension is mainly primary in origin. So most of them are from renal. So we have our nephrologists managing a lot of our pediatric hypertensions, and the cardiac causes mainly come in as secondary, and I would elaborate on some of them. So I had a lot of inputs from my nephrologist, who we work closely together. This will be my outline, and I'll try and bring out how we measure BPs in children. Remember, for us, we are always either milligram per kg or we are this per that. So that is just maybe something away from how the adults do it. Just so if you don't get anything from here, at least you know how to measure BP correctly in a child. By way of introduction, it's relatively common in our pediatric population, and some are undiagnosed. So I just got this stats from PU in March. Last year, we had 2 hypertensive encephalopathy patients as emergencies, and then we had 8 urgencies, and the total admission then was 189. Fortunately, I've not got that for this year, but I know we've had about 2. Hypertension in children, I would say, is statistically based on normative data. So for us, we use the centiles for age, height, and gender. So by this definition, 5% of normal children will be classified as hypertensives. And from Flynn et al. In 2017, that is what we use. So we're using blood pressures based on their percentile for their sex, their age, and their height. So this is a chart, ably Proficiency, we have it in our pediatric wards for all of us. It shows our centile charts. You mostly measure the height, you get the percentile, and then you chart it based on the child's age, and then you look out for the 50th to the 99th. And then I'll go on to show us how we do it. So our normal BP for us, again, is centile based. So we say that normal BP is when their BP is less than 90th percentile, or 120, less than 120, or equal to 120/80 for 13 years and above. So we say you're pre-hypertensive child if you're in the 90th to the 95th percentile, and you have significant hypertension when you're more than 95th. So for stage 1 hypertension, when you're within 95th to the 99th percentile, plus 5 millimeters of mercury. And your stage 2, if you are more than the 99th percentile for your sex, age, and height, plus 5 millimeters of mercury. And so this is just one of the definitions that we use. So our current outlook here is that we know that hypertension, as we know in adults, it's a leading cause of a lot of things. In the US, they're saying about 3.5% of US children had hypertension. I already talked about the ones we had in PU. Unfortunately, I didn't get the data from our renal clinic, but then we also have our prevalence. So globally, we have about 1%, 4% higher in adolescents. There's elevated blood pressure in about 10 to 20%. And then there's an increase in incidence in children, especially in adolescents, because now we've seen a lot of children putting on a lot of weight. So we've seen children coming in with obesity-related hypertension. The causes, like I said, about 80% are renal. So that's the primary cause. So essential hypertension from family history or obesity, or if there are any renal diseases, and I'll elaborate on all these ones, vascular diseases like the tachyarthris, neurologic causes, oncology, some may be drug-induced. There are also neonatal causes and other causes. So from age 0 or infancy, some of the lesions may be a renal artery stenosis or a coarctation, which cardiologists mostly would be called on to see, or when they have the renal parenchymal diseases, from polycystic kidney diseases, dysplastic kidney diseases. So we'll be hearing a lot of kidney, unfortunately, this afternoon, not a lot of the heart. And then in the children, again, if they have a bronchopulmonary dysplasia, can also affect it. Babies who are put on theophylline, caffeine, who are also on steroids, vitamin D intoxication, these can all happen and cause hypertension. Any child who's had some form of thrombosis to the renal vein, children with tumors, so we have the Wilms tumor, which is the tumor of the kidneys, or neuroblastoma, which effectively secretes hormones that go anywhere, pheochromocytomas from the adrenals, or a cystic kidney disease in the 5 to 10-year-old, mainly, again, cystic renal disease. And we also have some endocrine tumors. And again, in all these, obesity is also one of the causes. So in the adolescents, obesity, glomerulonephritis. So we can see that a lot of our hypertension, like I said, are mainly due to renal. And then hyperthyroidism can also occur. Definitions, Dr. Pepra nicely talked about it, urgency and emergencies. Where urgency is when there's elevation without end organ damage, and emergency being significant end organ damage. So for the purpose of this, again, he did talk about a lot of these. So thank you very much, Dr. Pepra. And our main concerns are the brain, the eyes, the heart, and the kidney. So any symptomatic severe hypertension is an emergency compared to an urgency where there is severe hypertension, but there may not be any evidence of end organ damage. Either ways, these ones we also need to be treated urgently, but not as aggressively as in the hypertensive emergency. So which conditions should we suspect hypertension? You have a child that you see, and any child that comes in with altered consciousness, any child with very aggressive behavior, you should suspect it. A child with seizures, presence of edema, if a child that has been known to have some chronic kidney disease or any form of kidney disease, you should know. You do a urinalysis or a dipstick. So now PU routinely we do dipsticks for all our kids. And you see that it's abnormal. There's proteinuria, there's blood, should be. And then any child coming in with heart failure, we shouldn't only think that it's just the heart, but then it's important we measure the BP. Any child who is obese, very more than when you, again, we always chart them. So when you put them on their central chart and they are obese, you have to also check their blood pressure because that may be the only time. Any child that's failing to thrive, a child that comes in with a stroke, or any child with a neurological deficit, a nerve palsy, you would want to be sure. A child with a low birth weight, history of a low birth weight. And so you realize that in our pediatric histories, we go into the pregnancy, the birth, neonatal period. We want it because it's believed that when they are born as low birth weight, you also have a small number of nephrons, and that alternatively also doesn't help much. It gives them hypertension. Any child with unexplained anemia, we know that the CKDs do that. A child with blurred vision, we said that the emergencies could affect the vision. Any child with neurofibromatosis, so you see the signs on their bodies. And any child with a syndrome, the Turners, who are very short because they have risk of getting the coarctations and the Williams syndrome as well. So I'll just spend a little bit of time here in how we do our BPs in children. We know that this formula stroke volume time, the pulse rate, we are looking at how BPs are measured in children. And for children, they have higher heart rates. We know that their heart rates will decrease with age. And so BP would vary by their age, height, and then their sex. So BPs, like I said, is age dependent. So when you're measuring the BP for a child, this is what we do. Mainly, you want to check the mid-upper arm circumference, and then from that level, you use about, and you should have made this child rest, arm resting supported at heart level. There is a child that probably has come in maybe a normal clinic OPD visit, and then you take multiple visits. So that's what we do. You want to make sure that this bladder, the bladder cuff is about 80% of the arm circumference, and then the width here is about 40%. That's the cuff that you're measuring. And we use the Kortkov 1 and Kortkov 5 for the systolic and diastolic. So mostly we take 3 measurements, and then the average of the last 2, or sometimes the lowest, is taken. So that is how we do it. So you realize that we have different cuffs for children, and we always say we have to use the right cuff, because if you use a bigger cuff for a tiny child, you would underdiagnose hypertension. If you use a smaller cuff for a plumpy child, you may also overdiagnose hypertension. So again, the length of the inflation bladder, like I said, there's a length here, should be about 80% of the mid-arm circumference. So when you measure the mid-arm circumference, that's where you put it. And then should be more than 80%. And then the width should be at least 40%. So if you don't remember anything, please remember that in children, we want to measure their BPs correctly. So the first thing in determining their BP is to check their height. So you have to check their height and then use the center for their age. So hypertensive encephalopathy is one of the emergencies that we see. And again, I think Dr. Pepper also did justice to it. I won't bore you with all the things that happen, but basically a severe BP elevation where you have signs of brain damage, so cerebral edema, because you literally have increased cerebral blood flow and the vessels are not able to constrict. And so you have symptoms that are as a result of cerebral hyperperfusion. And this rapid rise in BP will result in the loss of the BBB integrity. So other signs that you may see is a facial palsy, vision changes like blindness. And that's why a child that's coming with visual issues, you'd want to assess them, check the BP, or a child in a coma. So mainly it's a diagnosis of exclusion. When you've ruled other things out that may be causing it, then you would say that it could be a hypertensive encephalopathy. By contrast, because there are other things too that would also cause increased intracranial pressures like brain mass stroke. They are not mainly reducing the BP. So initial management, if you have a child that's coming in with an encephalopathy, seeing a child with seizures, there are signs of brain damage, mainly the airway, breathing, circulation, and you want to confirm the BP elevation with the appropriate way that I'd shown. If you have to determine if there are any signs of end organ damage, so from head to toe, Dr. Pepper through it nicely. And then you also have to identify any conditions that alter the BP management. Like I said, our main thing is that mostly when we have a child with a hypertensive emergencies, most of the time the nephrologists that are called or the intensivist, and then we come in as cardiology if there's a suspicion of cardiac cause. And it's very important for us in our history and examination. And I'll take us through some of the things we look out for. So in the history, it's very important that we ask about signs of hematuria. Has this child been passing any urine? What happened? Was there edema? Is this child having any form of decreased urine? Was there any joint swelling? Is there a rash because of the vasculitis, the rheumatology? And if it's a baby that probably had some exchange blood transfusion or anything that caused the umbilical vein or the artery to be catheterized, it could have resulted in the vein getting thrombosed. And so, or any child with a previous renal disease, this is a child that has been known to say maybe had some form of nephritic. It's important that we get those details. Is this child on steroids for any reason or the other? And if it's an adolescent or even younger child, you want to still think about any other illicit drug use. Remember, I said that for those with low birth weight, they have a small number of nephrons. So it's important we ask, and the same for prematurity. If the mom had hypertension, there's also a familial cause. Or if there's any reason, there's a child with an increased salt intake. And I had one of, so back where I trained, we had a child who had a cardiac transplant, but we realized that her BPs were just not being controlled. And we just didn't know what was causing it because, I mean, she was on all the antihypertensives, amlodipine, ACE inhibitors. And so one time we admitted her to just observe her because she was also not taking her immunosuppressants, Tacro and MMF. And then we realized she's from Congo, that she ate her orange by sprinkling salt on it. And apparently it was a delicacy in Congo. We didn't know that. I mean, so it was only when she came on admission that we noticed that. And they were all surprised. They said that's what they do. And she didn't really think that that was the cause of it. So it's important we ask certain diets, what people do. And it may surprise you some of the things that people do. So yeah, I mean, they take orange and sprinkle salt on it. That was a thing for me. So when we come to the clinical evaluation, radiofemoral delay helps us so well, especially when we're thinking of coarctations and then the children with Takayasu. And we realize that Takayasu also has a lot of cardiac implications because there are children that come. There was one child that had to have a whole aorta taken out and then a Dacron graft put in because of Takayasu, because had a huge or a massive aortic root dilatation that we were very scared that it was going to dissect. And then the rest of the arch also needed a bit of patching. So any child with radiofemoral delay, that's where cardiologists we come in and we want to rule out coarctation. On neurofibromatosis, where you see the café spots, you see the stigmata, the signs of diagnosis. And renal artery stenosis, we were all encouraged by Prof. Enchi during our pediatric residency, and even as we seen children, that we shouldn't miss the bruit of a renal artery stenosis, where you go laterally to the umbilicus and then you listen for a bruit. It may be the only time that somebody may pick it up. And then remember, we said that I did say that endocrine causes also are part. So any child that biggest genitalia, the congenital adrenal hyperplasias can do that. If you see a child that is dysmorphic for Turner's or Williams, it's important that we also check their PPs. Or any child with stanton, chronic stanton, we know that chronic kidney disease causes stanton anemia, or a child with edema, we have to check it. And if you do a urine dipstick and you see signs of blood or urine. So in the history, like I said, maybe a glomerulonephritis in terms of history of preceding throat or skin infection, and these ones I've already mentioned. This was a child that had, I'll present later, just a short, but then this was how narrow the aortic arch. This was a CT reconstruction. So this is a part of the thoracic or the abdominal aorta, and the rest of the arch very irregular when you go all the way up. Also had a very tortuous arch. So on the examination, we are looking for all these. So from head to toe, like we said, so you examine the brain, look at the reflexes, see what's happening. If it's a baby, you want to check, is there maybe a bruising or a laceration on the face or the scalp that is causing some form of trauma that may be intracranial bleeding, which may not really be the hypertensive encephalopathy, bulging fontanelle, hesophthalmos in the case of hyperthyroidism. And if you're having the discrepancy in the forelimb piece for coarctation, if you palpate the abdomen and you feel a mass, Wilms or a neuroblastoma, or a PKD, because the kidneys are not supposed to be palatable, it's important you think of that. Or if there's any bruising, maybe over the flank, there's been some form of renal trauma. And if there's ataxia, dysmetria, any form of focal neurological deficit, or the skin, which is suggestive of some neurofibromatosis or tuberous sclerosis or SLE, or a child with ambiguous genitalia. The investigations, again, like we've heard, it should be tailored. So we don't do all these investigations at once. You tailor it based on what your suspicion is. For black count urine dipstick, just to be sure that there is no blood or urine, blood or protein, and urea creatinine, the calcium electrolytes, uric acid, because that's also very important. And also to look at the kidneys, ultrasound them to ensure that they don't have any congenital anomalies, chest X-ray, because you may see a cardiomegaly from heart failure, and then echo to look at the LVH or any sign of end organ damage. You also pick up a coarctation if there is. And then fundoscopy to look at the eyes, because we said that it's also one of the end organ damages. And then the other ones, if it's renal, the nephrologist mainly will do the plasma renin activity. There's the MRA or the CT angio. That CT angio that was taken was for a child that came in with a neurological deficit. And DMSA, where they look at the kidney for any scarring. So if the child had recurrent UTIs for whatever reason, they do the scan and see how much scarring there is. Cardiac cath in the places that can be done, just because sometimes Takayasu, and I've seen a Takayasu who had literally almost all the vessels affected from the aorta all the way down, mid-aortic syndrome. And then sometimes you also check the urine for the vanillomandelic acid in terms of those that are secreting catecholamines. Our aim for BP reduction in the hypertensive encephalopathy in children is that we try to bring their BP to the 95th percentile slowly over 48 hours. So in the first 12 hours, so it's a third rule that we use. So 1/3 of the total BP reduction in the first 12 hours, the next 1/3 in the subsequent 12 hours, and the final 1/3 over 24 hours. So that is what we do. We use the 1/3 rule, 12, and then 24 hours. We aim to reduce it to the 95th percentile over 48 hours. Because we don't want to rapidly drop the BP. I think Dr. Pepper also nicely talked about it. We are worried about the perfusion issue to the brain, the kidneys, the heart. And so we set BP targets when they come in, we check their centile, their 95th, and then we set the target how much we are going to decrease the BP. We are not overzealous. We stick to the target, and we come down when it's done. So this was an 11-year-old. This child didn't present confirmation. Unfortunately, it was at a different center. 11-year-old was brought to a center, came in with a stroke and was aphasic. He had complained of headache previously, and then he had these signs of neurological deficit. He had been previously well. Father said he didn't have any issues, so they had been referred to a cardiac center. And luckily, they have the imaging done quickly, so they were able to do an MRI, which showed an aneurysm. Unfortunately, I couldn't get the video nicely for us. So they were referred actually to come coil the brain aneurysm, because that was the cause of the stroke in this child. But then they noticed that this child's BP was very high, 11-year-old, even for an adult. We know that a BP of 200, 120 was very high. And so besides this coiling, a CT scan had also been done. They came in and a CT scan was done. And then this child didn't only have the brain aneurysm, it was actually on the two sides. The neurosurgeons were quickly able to put in a coil in one of the, I think on the right side. The left side, they said they would just watch. But then this child had literally all the signs of hypertension, had the stroke, had from the aneurysm, had a coarctation, very irregular arch, and also had subarachnoid hemorrhage. And so in this case, the neurosurgeons were the first point of call to be done, while cardiology was also involved. And they came in with their protocol for subarachnoid hemorrhage, and they started the child on imodipine infusions. And then we came in with a slow reduction of the BPs while we waited to see what the treatment would be for the arch, because then he was not still stable for the surgeons to take him to help with the arch. So when the CT angio was done, this was how bad the arch was. And so the plan was over 3 weeks, when he was stable enough after the coiling, after the SAH had reduced, then he was sent for aortic arch repair, because it was in multiple areas, and we thought that just ballooning or putting in a stent was not going to help this child. So we could see how so probably the child had this hypertension, then went on unnoticed, developed the brain aneurysm, which ruptured it literally, and then it was all from the coarctation. So he went home. He was still aphasic, but then through physio, he was able to at least power was about 3 on 5 on the affected side, and he was sent home on oral antihypertensives for follow-up. And the other aneurysm remained stable. So the question is that there are some children who antihypertensive treatment may be contraindicated or need modification. So if you have an intracranial mass lesion, or if there's uncorrected COA. So this child with this high BP, we're very, very careful in the BP choice. So he was not a child that you go in with the IV medication of labetalol that we use here. And so these are the medications we use in PU. So we use the IV medication with our PP reduction, with round-the-clock BP monitoring, so that we don't drop it too fast. And then when we reach our target BPs, like I said, the 1/3, 1/3, 1/3, and we have the charts by them, by their beds. Then we start the oral antihypertensives. IV labetalol, though a very wonderful drug, but it's also, we mostly don't use it in children less than 1 year. We mostly will do the hydralazine, and we don't do the sublingual nifedipine. And we also avoid it in children with chronic lung disease and asthma because of the bronchoconstriction. So in our recommendations, we say that mainly when the children come in with the hypertensive emergencies, once the stabilization is accomplished, the nephrologist or intensivist guides the therapy, and if there are treatable or correctable lesions like aortic arch issues, then cardiology comes in. And it's very important for us to know what the prevalent etiologies are so that we can guide our medication. For the urgencies, we also treat them, we either bring them in as inpatients or we see them on inpatient to be sure that they may not develop the end organ fast as in proceed to emergencies. And then we are also gradual in terms of how we manage them. I guess for us, our first line for antihypertensives are the amlodipine, which we use a lot in our children. And then we bring in the ACE inhibitors and all. So that is the end of my presentation. I didn't want to rush and I didn't want to be over time. So I believe that for all of us going here, there's just a practice question, sorry. And which of the following criteria, if you diagnose stage 1 hypertension in a child? I believe you can all answer this question. Okay, so my take home is that hypertension in children is commoner than we think. All children more than 3 years should be screened yearly for hypertension. Please let us measure the BP in children, right, so that we don't under or over-diagnose them. Get different BP cuffs for our children. It's not a one-size-fits-all for our children. These were my references, and I acknowledge the input by our nephrologist, our PICU team, and PEU. Thank you, and over.
Thank you very much, Dr. Dutechi. This has been, once again, very insightful. We are grateful. There are so many questions coming in. We are grateful for taking us through the percentages and the percentiles and what to do and what to watch out for. We are grateful. Before we take any live questions, we would because we are still pressed with time, our pharmacy group that are with us, Intas Pharmaceuticals, take us through a 10-minute presentation quickly. To do that, we have Mr. Bobade Ejincha, if I'm pronouncing it well, I hope, to take us through what they have for us today. Again, also, our presenters are done presenting, so you can address the questions to each and every presenter. Please, the presenters, there are questions in the Q&A. You can answer some of them directly so that it saves time by typing in the answers directly to the questions. And for those that want to ask directly at the end of the pharmacy presentations, you may ask to raise your hand and then we'll unmute you. So I think Mr. Bobade is sharing his screen. We'll give him 10 minutes to share his thoughts with us. Thank you.
Pacho, good afternoon. I hope I'm audible to all.
You are very audible.
Yes, please. You're audible to us, yes.
And can you please see my screen?
Yes, please. Your screen is also very
Yes,
visible.
okay. So first of all, good evening to all the esteemed panelists, to all the participants who have joined this extremely enriching session of knowledge. I thank you all for this opportunity to be a part of this program, to let us share a few things about the company. Though I will not be standing in the question answer sessions, I will quickly have a small presentation about the company. As Dr. said rightly, this is Intas Pharmaceuticals. It's one of the biggest companies based out of India. It's a multinational pharmaceutical organization, and I'm sure you all must have seen either of the two products or either of the two companies, either Intas or Accord. So I'm really, really proud to say that Accord, which is a well-known company in Ghana as well, is actually a subsidiary of Intas Pharmaceuticals from India. We do business in UK, US, Latin America as Accord, and we do business in India, Asia Pacific, and Africa as Intas. So we are the same company. A quick facts that I would just like to share. It's a privately owned pharmaceutical company. The benefit of that is the decision making is quick. We don't have to rely on many people to make a decision. We are the leaders in oncology. 30% of the volume share of major chemotherapy molecules in key geographical areas is with Accord or Intas. We are the experts in developing as well as manufacturing the biologics, which you might be knowing as trastuzumab, bevacizumab, and rituximab. It's a company which has a vertical integration. That means right from the development of a drug to a clinical research to manufacturing and to launching it commercially into any of the countries, we have it all. When you talk about the revenue, this might be a little bit older figure. So we are currently at $2.9 billion in the global market. We are present in more than 85 countries across the world. We have more than 19,000 employees across the globe, as well as it is correctly said, we have more than 600 now, the scientists dedicatedly working towards the development of the new drugs. We have a strong pipeline of the products as well. As you can see here, we have more than 20 state-of-the-art manufacturing facilities. Most of them are in India, but we have 2 manufacturing facilities in UK as well as 1 in Mexico. As it is said, the company is amongst the top players in UK and the US generic markets. We take pride in our in saying that generics is something our forte, and we do lead some of the countries where market share is considered. In Europe, generic oncology market, we have a commanding position. Every third product used in UK in oncology is from Accord. As highlighted a few things that in autoimmune diseases, we are there. In animal health, we are there. When you talk about critical care, that means the injectable antibiotics as well as antifungals, we are there. We have a significant pipeline in oncology and hematology as well. These are the various awards that the company has won in just last 3 years. I'm sure you must be knowing those esteemed authorities. As it is said, more than 18 or 19,000 people. This is the actual head office of the company. As I said, a strong R&D team supported by the analysts. Millions of the people are getting benefited because of the biosimilars. We have invested more than $400 million only in biosimilars, which help in curing many, many difficult diseases. We are the first company to launch a biosimilar in European Union and shortly in the US. But by the time this presentation was made, we were about to do that, but now we have already done the launch in US as well. So this is the actual photograph of the facility where the drugs are manufactured. As you can see, this is a state-of-the-art building covering a huge area. These are some of the other glimpses of the facilities that you can see. One thing I would really like to highlight here is patient is the first person to touch the drug or the medicine by hand, because all the facilities, all the processes are automated by the machines. So it leaves a very, very small chance for the contamination or the drug being adulterated. So you can safely say that there is hardly any contamination in the products. You find it mostly pure. So not only business perspectives, Intas fulfills its role as a responsible corporate through our CSR initiatives. As you can see, we have the blood transfusion services as well. We have established 3 blood banks to support the patients for the blood components as well as the blood. More than 31,000 patients are provided with safe blood components in Gujarat. Gujarat is the state of India. I'm sure many of you know where the company is located. Thalassemia awareness and screening. We have reached to more than 7,000 students across 24 educational institutions. Free NAT blood tested components and thalassemia screening for the youths in college. Then we have constructed and operationalized a state-of-the-art educational and vocational campus for the hearing impaired children. Now coming quickly to the products, The product that really I want to highlight in front of you in the space of cardiology is rivaroxaban. As you all know, and I'm sure the doctors know it better than me, that rivaroxaban is a direct oral factor 10 inhibitor. It is 100,000 fold more sensitive for factor 10. It selectively, directly, and reversibly inhibits the free as well as clot associated factor 10. I'm sure the indication, just to reiterate.
We have 3 more minutes to wrap up. So
Yeah,
if you can
yeah,
do that,
I'll do that. Yeah. So
All right,
these are the
thank you.
indications that I'm sure you know. Just one important point to highlight here: rivaroxaban is not necessary for dose adjustment according to the age, gender, body weight, and race. So I think that's a very, very good plus point against warfarin. So Rivatas, I can proudly say, is the first generic of rivaroxaban in Ghana after the innovator. And we have done the BE studies, that is bioequivalent studies with the innovator, and proven to be non-inferior. So you can say it's 30% cheaper, but equally good. Apixaban is there something with us. If rivaroxaban is not a choice because of the low EGFR, telmisartan is there in our portfolio for the hypertension, that is the issue which is being discussed very vastly over here. Nilol is something a very old combination. I'm sure some of the senior clinicians here must remember this product being launched in that time, nifedipine plus atenolol. It's still available for some of the patients that you think this combination might work. Then a multivitamin called Intavita. I'm sure again it's been there since 25 years now in the market. So Intavita is something I'm sure all you know about. We have a combination and the individual pregabalin for your neuropathy patients, diabetic peripheral neuropathies. In the neuropsychiatry range, we have olanzapine as well as risperidone. And for this is just for an information for your CRC and breast cancer patients, capecitabine is also available in Ghana from Intas Pharmaceuticals. So these are the 4 major chain pharmacies where you can find all of my products, which is like Ad Pharma, Top Up, East Cantonment, as well as Unicom Chemist. So if you think Rivatas or Intavita you might I'm not getting, these are the 4 places where you definitely get it. So again, I thank you all of the listeners and the participants. I especially thank the Ghana Society of Cardiology for allowing me this chance to present here, to be explain my products and the company. And I'm sure now, with knowing the company's vast pipeline of the products as well as the presence, this gives a confidence for the clinicians to prescribe my products. I thank you again.
Thank you very much, Intas Pharma. Thank you for keeping to time. We are very grateful for your products too as well, which has been cost effective for a lot of our patients. So, like I said, we'll be taking some of the online questions. Please, the panelists, you can try as much as possible to be answering some of the questions in the background. Try to answer some of the questions online in the background for us as well. So the first question, if I may read, let me try and get to the question and answer session. Sorry. All right. Norbert wanted to know how does salt intake play a role in the development of hypertension? I think this goes to our first speaker, if he can speak to this.
Okay, Dr. Akomia, thank you.
Yeah. Dr. Korea, what speak to it? Maybe Prof. Inkum also asked a question whether we have arrived at the new 130/80 for the definition of hypertension. So you could also address that as well. Are we now using 130/80? Is that the new definition, the new threshold? Thank you.
Okay, thank you, Dr. Adekum. Yeah, for the first question, it's been known that high salt intake can raise blood pressure by increasing fluid retention, leading to increase in the blood volume. And so once your blood volume increases, your stroke volume increases, cardiac output increases, and that eventually causes the raised BP. And this will happen. This will happen because when you have high salt intake, the body will try to dilute the high intake of the sodium. That's so doing increases the total blood volume, the stroke volume increases, cardiac output increases, the BP increases. For Prof. Inkum's question, I don't know why he's asking that, but then Ghana is more biased to ESC, European Society of Cardiology classification of hypertension. Even though the 2024 review is so go by the BP cutoff point of greater than or equal to 140. So we are more towards that. It's the Americans that tend to have a lower BP cutoff, that's the less than 130/80, which was based on the spring study. That's how they came out of that one. But then Ghana is more towards or biased to European Society of Cardiology. So we are so using BP less than 140, less than or equal to 140, or greater than or equal to 140, whether the patient has hypertension or not. That's the answer for Finku. Thank you.
Dr. Jacob, would you want to add on, or can we move on to the next few questions?
Let's move on to the second. I think he also was looking at the threshold for treatment as well.
Yes.
If the definition is greater than or equal to 140/90, the threshold, are we looking at ESC and AHA? What should we be telling people?
Okay, thank you, Dr. Jacob. With that, I
It doesn't have to be
earlier,
Dr. Korea alone. I mean, Dr. Pipra, you can come in. It is just a discussion.
Okay, so as I was saying, Ghana is so more biased to the European Society of Hypertension and Cardiology, and the cutoff point is 140/90, greater or equal to 140/90 to be considered as hypertensive. But then, just recording that BP does not mean we have to start medication per se. You can start non-pharmacological management. But of course, we need to assess this patient holistically, where you want to evaluate for any other cardiovascular risk factors. Of course, we want to evaluate for hypertension-mediated organ damage. So that once you see hypertension-mediated organ damage, that will qualify for initiation for treatment. Otherwise, just BP greater than 140/90, that norm you have to start. You have to rule out the other cardiovascular risk factors. You have to rule out an organ damage before the person will be qualified for treatment or not. Otherwise, you can use non-pharmacological management. Thank you.
Thank you, Dr. Korea. I believe that was part of the reason why he was asking. So, not necessarily waiting for the BP to be so high. Between 130 and 140, Americans say it's stage 1 hypertension. Europeans say it's elevated blood pressure. But if you look at it, you see that there's some convergence in the decision to start antihypertensive medication. Even with elevated blood pressure, when there is evidence of hypertension-mediated organ damage, one may decide to start antihypertensives even at that stage as well. So, I mean, as you rightly said, evaluation of the patient, the risk factors that are prevailing at that time, I think is very, very important. Dr. Joseph, you may continue.
Thank you very much, Mr. Chairman. Yes, so there are still some pending questions that are yet to be answered. Let's just go through a few of them. So someone, Ijoma, wants to know that in what situations are calcium channel blockers, in addition to a diuretic, a good first-line antihypertensive, and is this always a good combination? I don't know if Dr. Pipra is on and can take this. And Dr. Pipra, whilst you are taking that, the next person also wanted to know if someone did come with a hypertensive emergency like a subarachnoid hemorrhage, what then should be your target blood pressure control in this person going forward?
Okay, thank you. So for choice of antihypertensives, I mean, one of my slides looked at that. So compelling indication, if a patient has heart failure, we know there are some 4 drugs the patient should be on. So you want to, if there is hypertension, you want to make sure that it includes those 4 drugs. For patients with MI, they should be on ACE or ARB, beta blockers, aldosterone. So you may want to choose those ones. If a patient has proteinuria, you may want to go with ACE or ARB. If a patient has angina, you may want to add a beta blocker, calcium channel blockers. If a patient has atrial fibrillation, again, beta blockers, and this time the non-dihydropyridine calcium channel blockers, the same for atrial flutter. So the patient presentation and then the other comorbidities may help you in your choice of antihypertensive. So it's always good to look at the patient's profile in selecting the antihypertensives to use. So that was a very good question. And then for the target in subarachnoid hemorrhage, similar to the intracerebral. So the intracerebral in particular, if you can use the general rule, but once there is hemorrhage, there is risk of hematoma expansion. And that is what the ESC recommends, that for that reason, we lower the blood pressure to below 160. We bring the blood pressure to below 160 within 6 hours. So for intracerebral hemorrhage, they looked at bringing the blood pressure to below 160 within 6 hours. For stroke, definitely said earlier on, I think most societies agree that we shouldn't be too aggressive in bringing down the BP4, but for hemorrhage, there is one of the 3 major exceptions I spoke about, where the goal is you want to bring the BP to below 160 within 6 hours. And the main aim is to prevent hematoma expansion. And this recommendation, if you look at their previous recommendation, is in variance. Their previous recommendation, the target was around 180, but their 2024 recommendation, I think other studies shows that reducing it a bit further helps to prevent the hematoma expansion. Thank you.
Thank you very much, Dr. Pepper. So as we are taking more questions, please let's also remember that in conjunction with Intas Pharmaceuticals, Ocular Pharmaceuticals were also very instrumental in bringing this CPD to everybody on this call. Thank you very much, the presenters. Let's take some more questions. So an anonymous attendee asked 3 questions. I think some have been addressed already, but she wants to know what is an adequate blood pressure to prevent hypertensive-mediated organ dysfunction and in an adult without other comorbidities. And he was like, also, what are the compelling indications in hypertensive-mediated organ dysfunction and the appropriate combination of antihypertensives? I'm guessing he wants to he's asking about the compelling combination to prevent HMOD and also those with established HMOD. What are your go-to antihypertensives? He also wants Dr. Pepra to speak to the dosage of IV labetalol for hypertensive emergencies. So maybe Dr. Kowa will take the first 2 questions, and then Dr. Pepra will chip in with the dosage of IV labetalol for hypertensive emergencies. I know he's already gone over that, but he also wants to know in emergencies like acute kidney injury, what should be the target? Thank you.
Doctor, would you please?
Okay.
Dr. Wachi, I'm sorry. Can you please go over that?
Yes, Dr. Kowa, I'm still here.
Can you please go over that?
So the anonymous attendee wanted to know what the compelling evidence for pharmacotherapy is for preventing hypertension-mediated organ dysfunction in an adult patient who does not have comorbidities. And then also he wanted to know those with hypertension-mediated organ dysfunction already, what is the appropriate combination of antihypertensives for these groups of people? I hope I'm clear now.
Yeah. What's but then what I want to say, the guidelines said you want to
Dr. Kowa, I don't know if I'm away from your mic or you're using a different mouthpiece now, but you're barely audible.
I'm audible. Okay, thank you. I was saying that I wish I could understand that thing of the person, but then what I want to say, as much as possible, you want to have low BP that the patient can tolerate it. So when your BP is, that's when it's more likely to prevent you from getting mediated organ damage. So you want to have low BP as well. And also make sure that you avoid or prevent other cardiovascular response. So you tend to have the hypertension-mediated organ damage. One, when your BP is, when you have, so that you want to prevent them, make sure you manage or and then you want to have a low BP so that the patient in question can be able to do that. Then you are likely to prevent or reduce or delay hypertension-mediated organ damage. And then about the second question, they're saying that one drug combination that no just one drug to treat all patients in terms of patient need to individualize the treatment depending on the level. But by and large, the combinations that are recommended by the guidelines are either ACE inhibitor or combined with calcium channel or diuretics. So we can start with these two combinations, depending on the patient compelling indication, depending on the patient level of BP. You can start with these two combinations and then closely monitor, and that probably will help you control patient well to prevent hypertension-mediated organ damage happening. Or even if it's there, probably if it's early, without aggressive, effective treatment, you can reduce it. In early stages of hypertension-mediated organ damage, progression can happen. Has especially which were a bit aggressive, right combination, right drugs, then that one can happen. Thank you.
Yeah, hello. So thank you very much, Dr. Kowa. Myself, I don't think I got everything clearly. Maybe it's from my end. But if Dr. Prepra can go ahead with his answer as well.
Okay, thank you. So for patient presenting with AKI or acute kidney injury, the general rule is to, you can use the general rule for hypertensive emergencies, which is to reduce it by about 25% within the first 24 hours. And this 25%, you do most of them within the first hour, which is about 10 to 20%. And then the remaining percentage over the next 23 hours. So that is the general rule, to reduce the blood pressure. Whatever blood pressure the patient has come with, you find 20 diastolic, and you try to bring the blood pressure to below 25% of that. And the problem with AKI is that if the patient has renal artery stenosis, then their presentation will be similar to patient with ischemic stroke. And in that situation, even using the general rule may give them problems. And for them, you may realize that reducing the BP, the renal dysfunction may be worsening. In that situation, those patients may be having the renal artery stenosis, where management will be similar to patients with ischemic stroke. And the three exceptions to this general rule was one, the ischemic stroke, where you actually don't try to bring the BP down at all. In fact, the ESC recommend if it's below 180, don't even give any BP medicine at all for the first 72 hours. Then afterwards, you start your oral medicines to reduce it gradually. So that is for ischemic stroke. You really don't try to drop that BP because it may worsen the cerebral perfusion. The opposite is for hemorrhagic stroke. In that situation, you try to bring it slightly lower than the general recommendation, which is below 160 in 6 hours. And then for aortic dissection, that one, you actually drop the BP. In fact, the aortic dissection is the only situation where your aim is to drop the BP from wherever it is to below 100 or to maximum of 120 for the systolic, because if you don't drop it, that pressure is tearing the aorta apart. So that BP needs to come down immediately within 20 minutes. And for labetalol, the maximum dosage in 24 hours is 300 milligrams. And you can start by giving 20 milligram IV. And then, so you do that start. In 10 minutes time, you can give another 20. In 10 minutes time, you can go up to 40. You can actually keep doubling the dose to about 80 milligram IV bolus. But once you hit a total of 300 milligram for a day, you stop. If you have a perfuser, that would be the best. So that one is very simple. You just do 1 milligram per minute. So you just set it up to run over 1 milligram per minute. If the BP is dropping too much, you can reduce it to 0.5 milligram per minute. If it's not going down as your target BP is, you can increase it to 2 milligram per minute. If you have a perfuser, that one will be simple. But if you don't, the bullocks, you do 20, the next 10 minutes, you can increase to 40, can go to a maximum of 80 milligram IV bolus. But once you hit the maximum for the day, which is 300 milligram, you have to look for something else if the BP has not come down. Thank you.
Thank you very, very much, Dr. for the submission. Please, there are lots more questions. Our panelists can go through and then answer some of them for us. But before we go on to a chairperson's remarks, we would want Dr. Christiana to please take this question for us. Dr. Pauline, so who wants to know what's the major cause of kidney-related kidney-related causes of hypertension in children, and how can we best manage and even prevent these? If you can speak to it, just 2 minutes, then we'll take the chairperson's remarks. That's Dr. Jacob's remarks right after that.
Okay, so thank you for the question. One of the things that the renal team have done is now we do routine urine dipsticks for children. So Prof. Entry and his team did the school screening where they just did urine dipsticks in school-age children. And they got a lot of children with kidney issues in the schools that were undiagnosed, because I think what led to it was we having children young age 6 years coming with end-stage kidney disease. So I'll say that is one of the things that we see, and it's the renal causes are mainly from chronic kidney disease, from maybe untreated UTIs, some renal vasculature issues. But the main thing is they come in with chronic kidney diseases, maybe from untreated UTI. So one of the things that PU now does is routine urine dipsticks, BPs, for all patients that come in. So that's one of the main causes. Thank you.
Thank you very much, Dr. Diteshi. Over to you, Dr. Ajapun.
Thank you, Joseph. I think you agree with me that this has been a very, very educative session. We've all learned a lot. I'm particularly thrilled about the pediatrics bit of it. We tend to think that children are small versions of adults, but I mean, we see that they are different and have their own constitution. That's very, very good for us. Dr. Akowia has taken us through hypertension-mediated organ damage and the need to evaluate patients well for all these hypertension-mediated organ damage. So once you are seeing a patient for the first time, or even when you are following your patient up, you need to take time and identify this hypertension-mediated organ damage, because they can change the patient profile, they can change your intensity of antihypertensive medication. So that is very, very important for us to incorporate in our practice every now and then. Dr. Prepra took us through adult hypertensive emergencies, and one particular thing I took from him is adult wellness book. He said adult weighing book or weighing card. I think it's something that will really benefit if we have adult wellness book to sort of every year you know what to do, and then know your numbers, your cholesterol, your BPs and things like that. That is very, very important. He also took us through the need for a fine balance in controlling your blood pressure in hypertensive crisis, whether hypertensive urgency or hypertensive emergency, the need for a very fine balance so that you don't end up causing more harm to your patient, and at the same time, controlling your blood pressure very well. I think Dr. Edutechi agreed with him on that. And one particular thing she mentioned, which I also took note of, is that all children 3 years and above must have screening for hypertension. And this is something we lose sight of. All our hypertension screening has been focused on adults. So this is something we all need to pay particular attention to and screen. And also the 1/3 in hypertensive emergencies in children. That is something we really need to pay attention to. So by and large, our presenters have given us a lot of things to think about and to put in practice. We are also very happy to have some of our senior members here with us. Sometimes it's this my imagination, how they are able to make time to join us all the time. I saw Dr. Amable with us. Thank you very much for always being at the background and helping us through all these things. GSC is very, very happy for that. Prof. Podonu was also with us. I don't know whether he's still with us. I mean, we are very, very grateful. A lot of us were trained by you, and you are still with us. Prof. Inkum was with us. His line unfortunately dropped. Today we were heavily oversubscribed. So some of the lines got dropped. And so we want to thank you. Dr. Tanko, the new CEO for UGMC, is also with us. Thank you very much for joining us. Dr. Lambert Tetapia, our General Secretary, ever present, ever supportive, is also with us. Thank you. And our President, Collins Kokoro, I think we acknowledge it would have been nice to give you all time to talk, but because of the pressure on time, unfortunately, we can't let all of you stop, but we know that you have a lot to share with us, and we will create those opportunities as time goes on. Thank you very much. I bring my case to an end. Thank you.
Thank you very much, Dr. Francis Ejekun. Thank you very much for your words. A gentle reminder that this event was brought to you by the Ghanaian Society of Cardiology as part of our May Hypertension Awareness. And to top it off, at the very end of the month, for those who were unceremoniously logged off and those who couldn't get the full benefit of what we have to offer with respect to hypertension and the discussions around it, we have a public lecture scheduled on the 30th. That's the very last Friday of the month at 3 p.m. at the British Council. So you can enter that on your Google Calendar, save the date, and then make a date with us on the 30th of May, Friday, at the British Council. Our very first public lecture, going to speak to hypertension and then how to modify our lifestyle or our lifestyle choices to best manage hypertension as it's becoming sort of an epidemic in our local or in our environment. So thank you very much to all the speakers. Thank you very much to our chairperson. We look forward to engaging more and more with you doctors during the month of May as we raise more and more awareness on hypertension. For those that we couldn't address your questions, you can always reach out to any of our executives or cardiologists, and then it will be addressed. Okay. All right. Thank you very much once again. I call this meeting to a close.
Bye-bye, everyone. Thank you.
President, you finally managed to say something. Thank you.
I was worried about the time, you know.
The behind the scenes people, acknowledge us why.
Hey,
Florence,
Florence Akomea,
you guys are
thank you all for
wonderful.
your great job. I mean, we acknowledge all of you. You know we can't do it without you.
Yeah.
Okay, boss, thank you.
Thank you. You guys are amazing. Thank you for pulling this one through.
Thank you, Presido.